morning. So today we have a exciting guest on our episode 4 of the Dr. Soul podcast, Mr. Vaibhao Ambhore, a program advisor in the family health at Path, and he has been the chief of party of USAID-funded maternal and child screening program called the Suction Project. A prior alumni from the Tata Institute of Social Sciences and with 14 years of experience in public health with a variety of domains from maternal, newborn screening to child health, supply chain management in the healthcare sector, and also mental health screening. So for the audience who wants to know a bit more about PATH, so PATH is actually a global NGO which operates in around 70 countries. And they actually try to connect healthcare, private stakeholders, and also governments to really create impact at scale. And they've worked in various domains, such as vaccine immunizations, using adopt affordable technologies to deliver care. So, Mr. Weber, thank you for being here, and we're really excited to have you on board. So, from your perspective and for the audience, what do you think? Actually, could you explain what PATH actually does to really be brief about it? And what role have you played in the past few years in the family aspect of PATH? And where do you see your journey leading forward?
Yeah. First of all, thank you for having me here. Talking about Path, Path is a very focused organization on innovation. So Path's broader motto is health equity through innovation and partnership. So equity, innovation, and partnership are three key terms that we pursue very rigorously at Path. And to give you an example, we look at the innovations that are being designed by the innovators in the industry or in the academia, and then help them get introduced in the public system or a healthcare system and help them scale. One of the examples you can see is uterine balloon tamponade that we know postpartum hemorrhage is one of the key reasons for maternal deaths. And there are options available, but you may know of like condom catheter can also be used as a uterine balloon tamponade, but it requires assembling availability of those things and as well as has a lot of issues. So Path worked with the academia as well as the industry to develop a uterine balloon tamponade that is that is very effective, and then introduced it across the world in India also, and it is being used in health facilities, saving lives during transportation and referral. There are hundreds of innovations that Path has initiated, like vaccine vial monitors, or fortune rise, or various vaccine carrier box. All these innovations are kind of Path played a key role in their introduction and scale. Coming to the work of family health portfolio focuses on reproductive, maternal, newborn, child health related public health support to governments. And here we have worked on improving availability of contraceptives of the health facilities through various innovations in supply chain. We looked at the maternal newborn health related innovations in terms of oxygen, in terms of providing technical support on various interventions for maternal health, PPH management. So all these are Path supports to the government. Going forward, we are looking at providing very targeted support and specific supports to government on various aspects, and more we are looking at integrating various health aspects. So coming under primary health care or looking at universal health coverage. Taking pioneering steps in digital health, combining the maternal health and looking at various technologies, let's say AI-enabled stethoscope or other technologies, looking at specific problems of either the providers or the community, and then piloting them, demonstrating them in health systems, and then taking them forward.
That's actually very interesting and fascinating that what has PATH been doing in the past few years. I mean, several years, to be precise. But the greatest example, what I've realized from the government of India is the ASHA workers, for instance. They have actually improved maternal and fetal screening. They are also very open to adopting technologies. But my question is, when you're connecting it to the family health perspective, right? The ASHA workers visit a home, and they generally evaluate the mom and the newborn, or the maternal and fetal health itself. What about the other people in the local household, the father, the mother? How isn't there a is there a good continuity of care in regards to that when it comes to the family health perspective? Or could we capitalize on the ASHA workers to training them to further evaluate other members of the family to improve better care delivery?
That's a very, very important point, and that's where the title of the talk we have is lost opportunities, and that is precisely what we can focus going forward. So, ASHA as a frontline workers, rather than being too deep on medical care, rather it should be wide on catching the early illnesses and educating the community and acting as a bridge to identify cases early and referring them to the health system. So definitely in illnesses, for example, along with maternal child health, when she visits for the health of the mother and the progress of the child, she can definitely look at the screening for hypertension and the various NCDs that government is focusing on, and looking at current programs of health and wellness centers, Ayushman Bharat scheme. They are trying to put together all these into a singular program. Health system has been very vertical. So we have different malaria control program, the neglected tropical control diseases control program. The mental health program is different. The tuberculosis program is different. So in 2005, so early in 2005, when NRHM was launched, all these were brought at least financially under one umbrella, and then slight coordination between these different programs started happening. But at the ground level, when different campaigns come, there is a need to find synergy so that when Asha educates a family about, let's say, antenatal care, she can also educate about anemia. It doesn't require any additional resources. So it would make her home visit more efficient as well as more effective. However, there are certain challenges of how much Asha can do in terms of her knowledge. So in that case, for example, in our project, what we have done is, and this challenge emerged from, or this methodology emerged from their discussion itself, that they find it more effective to team up with Anganwadi worker and the ANM, the auxiliary nurse midwife. And when a team of these three people visit, the family is more attentive and the knowledge base is much broader and the message is more effective. So all these three people visiting households repeatedly, sometimes for the same reason, may not be as effective. So there is a possibility of finding a very sweet spot where we customize certain messages and specify certain areas in which a group home visits can be facilitated. And for specific activities like immunization or follow-up of certain cases, the individual visits can happen. But currently we are missing out on looking at the family as a unit instead of looking at. So now we have started looking at mother and baby as a dyad, but we need to expand that to looking at family as a unit of healthcare.
Right, but Mr. Vaibhav, just like jumping in, I think as an Indian medical student who's like seen the Indian healthcare system at its core, I think all the three that you just mentioned, the ASHA worker, the Anganwadi worker, and the ANM, I think they are three of the most underrated components of the Indian healthcare system because of the service that they provide is, I feel like it's unparalleled. You are literally sending healthcare workers to your home. Like that is a level of care that is unparalleled. That's how I look at it. And I'm very proud of them. But as you said, there are certain challenges, and you talked about how we're missing opportunities. My question is, considering that they're already overloaded and they have so much, they're not in just not in terms of like their own individual responsibilities, but in terms of like the number of people that they're looking after, right? Um, Although yes, it would be more efficient to like have, these additional responsibilities given to them. Would that not overburden them? And if it would, like, is there something that as medical students or as doctors or as nurses or any other component of the healthcare setup that if we have in India, are there any other resources we can kind of funnel to them to kind of actually make this work practically, you know?
Yes, yes. And looking at the kind of, so I think there are some people that talk about Ashas, ANMs, carry out 86 different kind of tasks, and they on various programs they are ultimate, the ultimate frontline workers to take that care to the community. So definitely, so again, focusing on what an organization or a project can do, and then looking at later what the health system in general can do. As an organization, what we looked at is one of the concerns that they had, and that's one of the important areas to keep in mind is to make them party to the understanding challenges and designing solutions. Sometimes there are one-time surveys or one-time interactions with a small sample of them, and then the specialist will sit down and design a solution, which may not always work, and some of them work, but many of them don't work because the solution doesn't sync with their ground level realities. For example, just to give a simple example, for an ANM, and this example comes from our Africa experience, but so for an ANM doing immunization, for her the most important information on a vial of a vaccine is the expiry date. All other information for her is immaterial. But many a times that information is not printed in the large enough font or at the right enough place for her to be able to quickly look at it and then make a decision and go ahead with the immunization. So for her, the feedback came that we don't need all other information which is required by regulatory authorities, but for giving those at the ground level, they are not. That information is not required. So the feedback was given to the suppliers and this thing. So when the stock is specifically supplied for government, these kind of minor changes can be done to make their job more effective and giving them more uh, you know uh, more more help. Second part is, as you said, so many programs do have activities for them. However, ashas need capacity building. Ashas, ANMs, and others need capacity building in terms of prioritization. So how do you prioritize, let's say, a home visit for uh, uh, a follow-up care of a particular disease or a high-risk pregnancy case. For example, she needs to know that a woman who has a raised blood pressure or has gestational diabetes or any other complication will need repeated more visits, and she can prioritize that over other things, and then conduct her work. And then the health system needs to design her incentive structure in that way. And there are efforts done in that way to streamline her incentives and link them to the to the severity or the priority of health condition of the particular. So just to give you an example, we helped some of the ashas under our project to come up with a HRP tracking tool. Simply a simple paper-based format where they could write down all the HRPs that once she is diagnosed, once a woman is diagnosed as a high-risk pregnancy, then she becomes part of that list, and then there are follow-up steps that that particular format gives the ASHA, and then she is able to visit and maintain. So even while introducing that tool, we conducted a workshop, and there we gave them training on counseling skills, even how to enter a house and talk to a community. I recently visited Raigada, and the Ashas were saying that that particular introduction itself, which they were not doing earlier, has improved their stature in the community, and people are more receptive because they look more or they sound more trained and more professional. So So two or three parts to it. First is the capacity building in terms of software aspect, not training them on how to fill up reporting register and other things. Their challenges are how to convince a father who is not allowing his wife to go to in the hospital to deliver baby in the hospital. He says, deliver at home. I don't want to spend on this particular condition. So in some cases, so they find it difficult to counsel. So they need that particular counseling training support, as well as the tools and aids, the pictures and flip charts and other supporting job aids, along with the prioritization. This thing. So we all have our tasks, the Outlook task scheduler and meetings and everything. Asha, having so many tasks, doesn't have any tool to manage her calendar, to manage her work day. And that ways, there are so many, so many things that she has to do, and there is stress and other aspects. So definitely with capacity building tools and the support from the system, these things can be prioritized.
So I think I just have one short question before we move on. From a bird's eye view, can you just explain to me like this process okay, that you see a problem, you come up with a solution, and then that solution is implemented, right? Like that's the SOP. So where does path come in? Does it come in at the problem identification? Does it come in at designing solutions, or does it come in at the execution, or does it do all three?
Yes. So depending on the program that we are looking at, the intervention comes in. So in again maternal child health, what we did was we went in with understood, for example, geographies such as Assam, Odisha, Chhattisgarh, and specifically Assam, where tea gardens are there, where we have high levels of maternal mortality. We went in and we said that since this is a long persisting problem, we know from certain problems from literature, but we formed groups of ashas and understood challenges from them. So they and uh, we told them that you are advisors of the project, not the frontline implementers of the project. You are an advisory group for the project. We'll come every quarter to you. You will sit 10 people. You will talk about the problem. You will say how best that can be solved, and we'll provide you all the support to implement those solutions. So through that particular process, and we call it living lab methodology, human-centered design approach, where we look at the people who are actually doing the work, and then in such meetings, even mothers can participate, and then they themselves have termed themselves as, let's say, Prerna or Pragati. That group has named themselves. They said we are a Pragati group, we are a progress group, and we know what problems, and this is a particular. So HRP example that I told came out of that consultation, and not as a our preconceived notion about the challenge that need to be solved. So that's where that's one scenario in which we do all three design showcase, but we demonstrate, and our ultimate effort is to not to implement it across the district, but show in one district and then advocate with the state to take up that practice in other districts, so that when we exit, that practice continues. Otherwise, when the project ends, the funding ends, the practice can stop. So our focus is always on sustainability, and we try and do that. And in other cases, for example, private provider engagement is low. So then we specifically focus on that particular thing, and team up with the private providers association, the IMA, the NNF, the FOXY, and then bring forward that collaboration in consultation with government.
That's actually very interesting. You have spoken a full biodesign process. Uh, and I believe Path does really innovation on a grassroots level, right? When we compare to upcoming urban companies in the health tech space, they're not able to achieve that same impact that either Path does or any other value-based care organization does. Is there any reason that happens, or maybe they're not able to understand the problem statement, the urban health tech companies, and why many of them fail? That would be a very good understanding for upcoming companies to find the right problem.
Yes, and some of the challenges that I'll speak of have come from themselves. So Path is one of the organizations that deeply engages with innovators and on a very constant basis. And we are in touch with, for maternal child health 1213, under one project, innovators. And understanding their challenges and taking them, and then understanding where they can kind of improve. So they are very good innovators, like with IIT Bombay and various other academic institutions. The products are good. They solve that particular challenge. Sometimes, just to understand some of the challenges is when they are ready with a product, they somehow understand how the private procurement works, but they don't fully understand how the government procures.
Mhm.
What are the steps that government takes? How do they release various specifications? So many a times government specifications are do not cover the path breaking technologies or very new technologies. They don't have specifications for that, and then these products don't fit into those descriptions. So many a times, sensitization of the systems in terms of engaging with them and showing them that these are next generation products which need different kind of specification where these particular products will fit is one of the challenge. Second is the ability to provide at scale. So when we talk about, let's say, 30 million pregnancies in India or 65,000 children being born in every day in India, so whenever we take a product to a particular state government, they will say if they like it, they would need lots of it and very soon. So that's one of the challenge. So in public setting, I would say specific hospitals would need limited number of this thing, but ability to scale and availability of funding for that particular product would be a challenge. Then some like very few, many of them do understand, but many of them may not account for the ground level challenges such as the power cuts, weather conditions, specific India being diverse country,
Right.
right from Kashmir to Kanyakumari. That's one particular thing. And then specific biological situations, such as, for example, a non-invasive hemoglobinometer will use a fingertip like a pulse oximeter to estimate hemoglobin. But we have such a different types of people, and if a worker works with bare hands, their skin type will differ, their pigmentation and all these factors will have bearing on how the product functions. So they will have to conduct a lot of very varied sample testing at various places. So that's where some of the disconnect between the innovations and the need of the health system comes.
Actually, that's very interesting because there is a lot of big disconnect between private players and the government players as well. You had mentioned, I mean, just a while ago, you mentioned about the anemia screening, and you've done a lot of work on that. I really want to understand what is happening in terms of anemia screening and PATH, and what is the core problem that PATH is trying to solve.
Yes. So anemia being so we had like anemia first publications, but so as a health system all over world, I think 1870 or something, anemia was recognized as an issue, and we still have anemia and are dealing with it, and large proportion of the population. So part in recent times, so there are other partners who are working on this condition and supporting government. So path role in recent times we have understood. So we have understood the key challenges in 15 states of India, taking a broad sample, uh, talking to right from the beneficiaries to the higher level policymakers, and understanding what are the key challenges, and then a specific component wise providing recommendation or working on recommendations to do that. But along with that, we had done earlier work on providing point of care diagnosis for hemoglobin in order to in terms of working with the innovators who have point of care devices such as TrueHB and other devices who are which are using the invasive method or neat taking. But now there are few innovators who have come up with this non-invasive hemoglobinometer. So we, rather than focusing on a generic problem of capacity building of healthcare, raising awareness and other thing, looking at specific problems of let's say screening for anemia through non-invasive hemoglobinometers, looking at options of IV sucrose or even FCM ferric carboxymaltose. Government has notified these things in their guidelines, but haven't been able to procure in good enough scales due to variety of reasons in terms of tendering process or in terms of various supply chain issues. There we are supporting the states or and helping the states prepare broader roadmap to address anemia. And again, the focus is not on creating a vertical program or making it a vertical approach, but finding the platforms that are already used as village health sanitation days or the checkups at the health facilities as a forum where anemia can be one of the components rather than again, because once you take up a space, you are taking that space from other program.
Right.
When you prioritize, for example, when there is a huge campaign on a particular disease or this thing, where so the let's say IFA tablets that are to be distributed throughout the year may get exhausted in a campaign mode, and rest of the year you may not have
Hmm.
sufficient stocks. So there are certain uh, trade-offs that have to be made. So again, alternatively, why make anemia a problem only of health system? Why not look at the other forums? For example, self-help groups are there. So every state has and national level we have livelihood missions, and they form self-help groups at the ground level where women get together and work on microcredit and do some livelihood related activities that improve their incomes. Health is one of their subject areas which hasn't been tapped yet. There are examples of Jivika platform in Bihar which have been very successful in participating in family planning related activities in terms of provision of contraceptives and this thing. So we are yet to tap this large potential of self-help groups. Many are present at one village level. There are 7, 8 groups, 10 women each, and these are the people who are the beneficiaries or even target population for these anemia related or any disease related intervention. They are basically the this thing. So when we make them party to the design and delivery, and there might be entrepreneurial models where they bring in the diagnostics, they bring in a local lab to test people at an affordable cost in the village itself, and then refer them to the health system. A lot of the work that health systems finds it difficult to do due to resources, one ANM, one ASHA. These SHGs who have a mandate of engaging on health also can work very well. So we look at such options. So NMMO SHG is one of the initiative in our project where we are looking at sensitizing the self-help group. So we have partner Piramal Swastha working on this particular initiative to bring in self-help groups to work on the cause of anemia. Just see the thousands of self-help groups and the millions of members that are part of it can become champions of anemia prevention and control. So these are some of the things that we are looking at.
So it's like more of a community approach. What I understand is, I had a very different question. So basically, let's take an example of anemia, right? The whole process, from path to the government to the local community. So the problem statement was anemia. Then path came up with some sort of screening modality to be non-invasive by collaborating with its private partners or players. Eventually, the problem the government faces is a supply chain issue. And okay, once you screen the anemia, then the majority of people, why they have anemia is because of poor nutrition, iron deficiency, folate deficiency, B12 deficiency. So, and okay, then I understand you're trying to connect the communities to help the people, let's say, curb undernutrition. So, how does this whole thing work? There is a challenge. I see it every step, and I know Path has addressed those challenges. But let's connect this to a person who wants to achieve scale. I see challenges in supply chain. How do you penetrate the rural areas very well? I see supply chains in creating a community, number two. And how do you also educate these patients who have been screened for anemia? What is the black box approach you
Yes.
follow? Yeah.
Yes. So definitely these are different components, and government with its large machinery along with various development partners. So like there are multiple partners, UNICEF and others are also working on issues related to anemia. So through PATH, we looked at specific problems of understanding those specific challenges in terms of screening, supply chain, and community engagement, and through different projects. So community engagement example I just shared, And then first demonstrating this non-invasive screening method at the ground level, looking at, because these innovators also need to further demonstrate at the ground level, make tweaks to their products in case challenges in terms of reading or ground level implementation. So these are still early level interventions that need correction at the ground level to be able to scale. But these are the problems at the initial stages which need more attention. So in terms of so the other challenges that you mentioned, educating the community, it happens through multiple channels. The government's IC, information, education, communication, behavior change communication initiatives, the T3 camp, test, treat, and talk camps
Right.
that are conducted, and education of the beneficiaries at the ground level. So in terms of preparing material or using the government's material in the programs at the ground level, translating them and then making them available at the frontline worker level are some of those initiatives. So rather than taking a very spread out approach, we focus on specific problems and specific solutions, and then demonstrating that, and then recommending that for scale.
Mr. Vaibhav, I mean, the idea from like this is what we want, and you're able to execute on it, using the resources that you have and like kind of filling in where you don't have resources, right? So, is it correct for me to say that you guys are excellent at logistics and you're able to really execute on work that the government wants to do or that you feel is the need of the hour? I feel like that
Yeah.
is that
So
is a rudimentary assessment of what Path does.
yeah, so broadly, you can say a technical partner. That's what we
Right,
call ourselves, a
right,
specific technical partner to look at specific technical challenges and focusing on innovation where we can have specific solution. And there are various organizations specializing
for
in
sure.
specific areas. For example, capacity building. So capacity building at a broader scale, we don't do as much, but we look at capacity building in terms of innovation. So let's say UBT introduction or other particular technology introduction. And then when supply chain comes as an issue, we look at that supply chain issue for, and not for particular drug, but the whole essential drug list. So
Right,
what are the key bottlenecks that are, let's
correct,
say, right from the procurement to final mile distribution. And just to conclude, Path has done so much of work that we still get educated on in
right.
these 70 countries in terms of the breadth of the work Path has done in terms of product development to the community engagement levels.
Very, very impressive. So I think I have one more question for you. And that is, as you said, there are a lot of technical problems. You look at yourself as a technical partner to the government and to the Indian healthcare or to the global healthcare system in general. So are there any challenges or are there any like in the present day, are there any challenges that are not so obvious to the human, to a normal human that you think that you have encountered through your experience that you would like to share with us? Something that, might take even Mohit and I, being physicians in India, like something that we might never have thought of, but it is a real bottleneck and it is a real challenge. Like one of the examples you gave us is making that expiry date bigger might actually help. That's something that we never think about intuitively. So I mean, if you can share one or two more of those, I think that would be that would be a real treat for our audience as well as us.
How do we think?
Yeah.
How do we think in that
Yeah,
way? That's the biggest
yeah.
concern.
Probably not at a micro level, but at a macro level, what
Yeah.
we see is the level of household formation that will happen in India when we migrate from the combined families to nuclear families. We'll
Right.
have more and more household form. Then, looking at the demographic transition, we'll have more and more, people with so older people and
Right.
smaller families and older families with fewer relatives. So the kind of healthcare that we are looking at, where we assume there is someone with a surgery patient to be with them, and there will be a social support system that we assume.
Wonderful.
But let's say in 1950s, there is a study that says that an average 65-year-old woman globally had around 41 relatives. And now in 2095, let's say in 40 odd years, the number will drop to 25. And these 25 people will be more of parents, grandparents, older people, and fewer of the nieces, nephews, and brothers and sisters.
Mm.
So we are moving towards a very unique composition of the patient groups that we are. So we will
Very interesting.
encounter a person coming alone. So the whole health system has to be designed, or the provision of care has to be designed, keeping this factor in mind that, let's say, at a home, you will not have a mother-in-law or a mother taking care of the baby. Then how do you educate about breastfeeding? The both mother and father will be working. So in such situation, what are the problems that a child is likely to encounter in terms of interacting with very fewer people? What
Right.
are the mental health condition, or being in constant touch with the screen? So I am very intrigued about what is it? How do we design, let's say, a maternity experience, in terms of there are no other women who are constantly behind the lactating mother in terms of feeding her certain things and this thing. That social structure will go uh, soon, and it is
Amazing.
absent in many of the urban areas. And there we still our counseling, our experience of the patients is attuned to the older ways of assuming that
Right.
structure, that some of the things will be taken care of by people, just to also focus on certain aspects. Let's say the way our machines work. For example, the constant beeping of machines. It's really frightening for people that when it starts making sounds and this thing. Once if you have gone through MRI yourself, you will understand
Yeah.
the experience that many patients have. So looking at the 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 whole look and feel of the healthcare in terms of ICU or a patient undergoing a treatment is wholly different for a patient in terms of being afraid of it, the social support structure, being able to say two sentences before you prick a patient. All these things are very important and will be crucial in tackling with in treating more educated people. So these are some
Incredible.
of the thoughts that I'm thinking, that this thing. For example, even like quality, marital quality, the people, the kind of marriage you have, or the kind of relationship you have with in-laws, has bearing on the child care, the nutritional status
For
of the
sure.
child, which never get explored. So if there is a
Right.
domestic violence and other things, one should look for, the doctors need to be sensitized for this thing. You keep treating a patient, and they will come back with the same problem. They'll fall back unless you counsel them and refer them to like child protection services or other things. Those things, unless they are cured at a social level, we may not be able to sustain the gains that we do.
I think
So,
Uh,
before the next question, I just want to add in one thing. I
yeah,
think you
yeah,
just explain. I think you finally explained to us what you treat the patient, not the disease means. You have to look at the patient outside of just the medical context and like take into account all of the socio-demographic things that are going on. Those factors that as physicians we normally kind of we consider, but we never take them seriously to the point that that you kind of that you shared with us. So I think Mohit, you can
but
take over.
Sharon, to add to this, I think so. This is a global problem, right?
Yeah.
How do you balance the workload of a physician? Because India has shortage of doctors. Even every other country has shortage of doctors. So how do you balance the workload of a physician, the doctor who's treating the patient, manage the patient's well-being, provide continuity of care to the patient, and also address the root cause of the disease?
Right, because
That
I mean,
seems
I
that seems a
agree.
big task.
Because in India,
yeah.
like I mean, in India, for example, like you're seeing 100 patients, 150 patients in an OPD. You have like 6 minutes per patient barely. It's not, you're not going to be able to sit down and have a chat with the patient and talk to them, even though if they were able to do that, it would have been beneficial in the long run. Right. So I think again, those are
So
challenges. Yeah.
no, but just to reflect on this particular challenge, I don't think doctors need to do this, and rather
Right.
doctors are not the right people to do it. They may be good at advising and this thing. So hence we see very few counselors at the health facilities, and they again they are dietitians or other specialized people, but we hardly see counselors at the hospitals who are not as their budget is the budget requirement to host a counselor is disproportionately low to compare to the value they can add.
Right.
So
Correct.
when patient has hundreds of queries and we barely utilize the OPD waiting time of patients
Right.
to educate them. So if we have health education cadre or the counselors for IPD patients and the health education cater, which can, and again we don't need again humans there. The television sets put in the OPDs repeatedly playing certain messages in terms of educating the patients goes a long way. And now we have smartphones in everyone's hand. So the potential, if we are willing to look at a particular challenge to solve it, so keeping aside the medical viewpoint, multiple potentials are there in using the OPD waiting time, in using the counselors in the facility. For example, a person undergoing an operation doesn't need 2 minutes from the doctor, needs an half an hour from someone who will say that I have seen hundreds of such cases. I was their
Mm.
counselor, and there are certain things that patients are not aware, and doctors assume that they will know in terms of wound care. For example, this doctor won't have time to explain that. But if patient doesn't take proper wound care, we have chances of infection, this thing. So it has a medical bearing also. So we have to balance between getting those resources for people to for educating the people and giving them support and giving that particular. So we see, I think you also may be aware, in US especially, so the lawsuits against medical malpractice are more towards the doctors who are not necessarily the less competent, but who spend less time with the
Correct.
patients.
Correct.
Not
Oh,
the
okay.
the doctors who may be excellent with very low rates of errors still get sued because patients think that the doctor doesn't care for them, and the
Right.
patient who may have higher rates of errors and not by their own fault. It's a logic. It's a fair error, but who take their time to explain with the patient hardly go against the doctors. So
Right.
these are certain things that need to be integrated. Even standing up and saying hello will make this thing. And but I understand the situation at the medical colleges and where we where we can't even look at the face of the person before start writing their prescription. So definitely, but there are other caregivers who can take up that work.
But I think, Mr. Vaibhav, you've just given us like so much to think about in terms of like what are the gaps that we can optimize, like gaps, like just the idea of having a counselor in an OPD, just addressing questions and nothing else, or having like a automated FAQ addresser system for every OPD. I think that can severely improve a patient experience. And as a patient myself, I would feel highly supported and I would rather be seen, or I would feel attended to, just if even if it was not a human being, but it was a resource or
Some
a
sort of,
package built for me. Exactly, right. Right.
Yes.
yeah,
For
actually,
example, if you walk into an OPD and you tell that I'm here for a joint pain, you
Right.
click joint pain, it will start telling you information that this
Yeah,
is
I
how you
think
can
that
take
is
care of
amazing.
yourself. And
Mhm,
such.
mhm.
That is amazing.
It's
That is
actually,
amazing.
that's where I think so large language models can play a role because
Yeah.
example Ayushman Bharat, right? So maybe last year I was volunteering at a local hospital in Jaipur, and so the doctor mentioned that they get 800 rupees per bed per day, the hospital, from the Ayushman Bharat scheme, which is like $10 a day, which is very low to give a bed to a patient. And I'm just wondering how you become India should actually be classified as the best example for resourcefulness. How
100%.
to allocate resource effectively, how to really not make unnecessary treatments. But obviously, I feel there's a gap in preventive care strategies. There's a gap in patient education, which can be addressed by technology such as, again, large language models and Sharon, as you mentioned, automated FAQs. What are
Hmm.
your thoughts on this? And what can the future innovators do actually to address the challenges which you see on a broader scale?
Yeah. So maybe in terms of technology, so broadly, I think we're looking at technology and solving the challenges with technology and what are the possibilities of it. So these challenges or approach can be bucketed in three major streams. One is the technology itself. Second is its adoption, and third, after adoption, it's the ecosystem coordination. And all these three factors are important. Many times we focus so much. So if we look at, let's say, inverted pyramid, the most of the times goes in designing the technology. So the whole effort that goes into, then the smaller effort is going into its adoption of the innovators themselves and the system itself. And finally, the stakeholder coordination or the ecosystem coordination in terms of putting in processes so that that particular system becomes the only or becomes integral part of the system and takes away. So many a times what we do is we introduce something in the system, but we don't tell the system what they need to take out. Many a times we miss that we should clearly specifically tell them that these are the 10 things you should stop doing and now, because it is not needed. This my particular system will give you the analytics. You don't need to fill this format. You don't need to do this. There are backend analytics that will give you this information. So many a times new formats are given, but this thing. Second part in terms of the challenges or this thing, the standalone development of applications. So many a times interoperability is an issue, and many a times that the uh, uh, also we have to be sometimes bold enough to recommend to the system to scrap their old systems. Many a times we become flexible or innovators become flexible in terms of integrate let's say a Ferrari into an older steam engine.
Right.
They don't just fit
Right.
together.
Right.
That they have to kind of let go, put that in the museum, and then start building the infrastructure around for a much faster, much advanced systems. So many a times, due to resource constraint or many various dynamics, that particular point is missed, and then the whatever is uh, there is as much that a previous system can be improved, and this thing. So restructuring or complete overhaul is important in some cases, and then in newer cases, interoperability, for example, UPI, and you can use it multiple banks and this thing. Such particular kind, which government is now doing with the sandbox approach and ABDM, a digital mission, this thing with Abha ID for everyone. These things are being done, but if we see the chronology of if we see the development of these particular initiative, first we came up with let's say HMIS, which helps the health system to capture data. Doesn't
Right.
directly benefit patients or doesn't directly benefit doctors even. It just gives the information to the program managers or resource allocators. But now we are coming to the tools that directly help the patients or directly help the doctors to deliver the algorithms for decision making, clinical decision support algorithms, and this thing. Now we are talking of that. I don't think we needed AI to design good algorithms. Even they could be paper based or IT based. But now there is recognition of those things. So looking at bottom up, looking at what at the point of care, what are the things that will improve the care is important. And
Yeah, that's
fine.
sorry.
Yeah, and just to give an examples of, I'm always um, thinking that we when we talk of the future, there are certain parts or there are certain problems in which we are still living in the past. For example, like India, when I joined public health, India's maternal mortality was about 200. So 200 women died after per lakh live births. Now the number is less than half of it, 97. So
Right.
within 14 years of my career, I've seen we are saving 100 per lakh
Per
live
lakh,
births.
yeah.
But if we disaggregate that into state-wise numbers, so Assam is still near 200. So at the 2008 India levels, Assam is at that level now, and states like Maharashtra or Kerala are at 40s. So so the worst state is 5 times as worse than the better performing state.
Better
But the
performance, right.
average hides it, the 97 average hides it. So we cannot have the same solution for both these contexts. We will have to customize. We will have to prioritize certain things in the place where there is 200 and place where there is 40. We'll have other conditions kicking. And again, we are at 97, but we have Sri Lanka, which is 29. So
Right.
a neighboring country being at 29, we want to aspire to that. And then finally Canada, US 9 and 18. So the future has arrived, but it's not evenly distributed. There are certain parts which are there, and certain places where we are in future, we are looking forward. Thankfully, we have some time machine like feature where we see where the developed countries have been, and we are going there. We want to go there,
We
so
can
we
jump
will
there.
inherit the problems that are there, and we
Right,
can preempt them and
right.
I think
hopefully solve them.
I think so. India is rapidly adopting technology compared to other countries.
We're
Definitely.
we're taking leaps,
Because
100%. Taking leaps.
example, till date, I'm taking an example of ASHA workers. AI has not been used on the hands of ASHA workers to screen maternal and fetal health screening. And I think so that's the perfect approach. And this was years back. That means not very recent either. One question I had was, as we are mentioning about digitalization in India, a vision that Sharon and I both share. So, what do you think is the problem in current digitalization of India? Because, example, in the recent past, I've seen many EHR records coming up. Is digitalization in India just based on EHR records, or it's a whole broad concept? And many of the electronic health medical records are not addressed for the local community, because I know Path, what it does is it bioinnovates for the local community. How can electronic medical health records be innovated for the local community, for the rural settings, and really make an impact to gather quality data? So this will help Path maybe or any other organization innovate at a micro level and at a macro level.
Yeah. So what one of the specific example Path is doing is to its digital team. We have a digital team. They are supporting the government in getting the private providers on ABDM. So many a times the technology adoption or the system that is developed by government is taken up through certain measures, systemic approaches in public system. But public is a part of the healthcare, and
Right.
private system, many a times the private providers are the first providers for people who go to them during evening OPDs and other things. So getting them on the ABDM platform, trying to generate ABHA IDs for the patients and this thing, which will, and again that can integrate into seamless other opportunities. So in terms of health records and medical records, these things have started, and slowly that will migrate to that particular situation where we have an integrated approach and one software approach where people will, and we have demonstrated that in EVIN, where the whole immunization happened through a seamless various 32 states with different system seamlessly plugged into the system, various private hospitals, and the whole immunization was done remarkably quickly.
Hmm.
So that can be demonstrated where there's a system. Where there is a challenge I see is for the patients. How do we integrate them? How do
Hmm.
we? And there are sporadic efforts to this thing where people should be able to take up self-care related initiatives. How do they take care of themselves in terms of, let's say, contraceptive use? Do they always need to consult a private provider in terms of a provider or a physical visit is required to continue the contraceptive or switch a contraceptive or various things like this in
Hmm.
terms of testing their own sugar and this thing. So there is a lot of potential of task shifting in terms of empowering the people, and that's where scales will happen. So once something needs to be pushed through a system, it requires a lot of integration and a lot of systems level alteration to be able to scale it. And then the system continues to evolve. But if there are systems that directly interact with people and people register on those systems or use those systems to educate themselves or use that system to access care, then that particular thing, and there is a great potential for preventive care in that
Right,
using the technology.
Mhm.
right,
That,
right.
that's actually very wonderful, because Path has a very deep understanding of micro minuscule problems. Just to end things, what advice would you give to us as future
Future
physicians,
doctors. Yeah.
future doctors, if you want to create impact, if you want to create technologies that are addressable to rural areas, to even urban areas, and to also remain profitable at the same time if you are trying to create impact. How do we synergize impact, profitability, and advise as future innovators, both Sharon and I, to eventually make a difference? That's what we want to
At scale,
understand from
at scale,
at
at
scale,
scale, at
economies of
scale.
scale.
Yes.
Yeah.
Yes. So again, it's a broad question, multiple answers, and I will contribute my bits to it. But what I see is when one looks at healthcare, and it probably happens with other sectors also, is to be able to is to the risk is of being having a narrow vision in terms of limiting the healthcare to hospitals, clinics, and doctors and this thing. It is very important to map all the stakeholders which can play a part in scaling and innovation, and not just health. Like we look at Ministry of Health, but there are so many other government programs
For sure.
that have livelihood component, the Panchayati Raj institutions. So never lose sight of the different stakeholders. Let's say railways, defense, all of them provide healthcare, and many of the innovators don't approach these institutions to kind of take their product to them and this thing. It is usually very narrow focused on private providers, let's say big hospital chains. That's it. But there are a lot of other
Avenues.
entities, avenues where which can be approached, uh, and also it is more logical to do that because there are uh, there are intersectoral factors that affect health.
Right.
For example, if we just improve the gender parity or gender equity in a region, the
Hmm.
malnutrition drops by 10%. If we increase the gender this thing, you don't have to. So a converse would also be true that if we are not able to address the gender issues, no matter how many times we improve the nutrition, the kid
It
may
won't
fall back
matter.
or the problem may persist. May
Right.
persist. The first line of the reasoning is there, but second line can be inferred. So
For sure.
what I am suggesting is to first the make the canvas as broad as possible, um, thinking in terms of what all things can be brought in under the umbrella of possible clients or possible um, possible audience for that particular innovation. We don't need a doctor or a hospital just to champion an innovation. If somebody gets really interested, even Nandan Nilekani can be like
Right.
bring in such innovation which help the health sector like Aadhaar and
Right.
other innovations. So
Right.
so sometimes we become very this thing. And second is the not to forget the social determinants of health
Right.
in terms of many a times the biomedical approach overpowers this thing. So sometimes you need to question whether I have a medical anthropologist in the room who will tell me that the who will tell me that your this thing particular. So in one of the recent, I heard somebody saying the culture eats policy for lunch, which means
Right.
that culture will overpower your policy, your all innovations. But once we
Correct.
don't understand a particular culture in the region,
Correct. Correct.
and that particular thing can kill. So it's important to interact with. So we kind of try and have economists in the room for unit economics and everything. But
Oh, okay.
anthropologists, social scientists are usually missed. So even if we don't have them in as a part of the design process, they are a key stakeholder to be consulted in order to targeting your segmented approach for this needs to be and how do we kind of make our pitch, which private sector does very well. They are masters of selling us things. That's sometimes things we don't need, but they appeal to our social conscious and not our health,
Because they
not our health
understand
need.
culture. They understand culture, and
They
when they're
understand
part of it,
culture,
and then
the
part of
social
it is because
approval.
yeah, and the reason is that they are a part of it, right? And they
Yes,
create culture, and that's why they understand it and they can shape it. I think that's the.
yes,
But I think to your point, I mean, I think this podcast kind of came about from that idea that we need to broaden our canvas and we need to understand all of these different stakeholders in medicine, not just in medicine, but in health.
Yeah.
Because I feel like, and I think we share your view that, I think sometimes as physicians, we can become a little bit possessive or unipolar in our approach. in the sense that, okay, this is what I'm supposed to take care of, and this is my responsibility, and that's it. But if we open it up a little bit, like for example, I think the last episode we had an architect come on and talk to us about how hospital design can improve the patient experience. And I think that's the way we want to take this podcast forward as well. So I think this was great. I think Mohit, if you want to add anything, we can uh, wrap
Yes,
up.
definitely. I mean, what I've felt from this podcast was it just opened the minds that you shouldn't just restrict yourself to doctors or key stakeholders, but you should also broaden to patients, like
Yeah,
patient-centered design. That's a new thing that has been approached in a unique way. For example, NHS, right? NHS does that. They do patient-centric design to innovate and improve the healthcare system, and they started recently, 1 year ago. The same with many European healthcare providers. That's what they're doing. And I think so. Path has been doing that for a very long time,
long
patient-centric
time.
design, human-centric design. And this can be connected easily to the previous podcast of the architecture itself.
So I
And
think it
and I
was,
think so. It was wonderful having you, Mr.
yeah,
Weber. I really appreciate that you took the time out to be part of this episode. We learned a lot of concepts. We shared a lot of knowledge. We tried to understand what can be done to improve the healthcare system at scale, and not just focus on big chain hospitals.